Down here. Good afternoon, everybody. Welcome to the CCR1. And from the Department of Radiation Oncology, NCA Jazzer, we are presenting a very interesting case today. And we'll see that how the new technology in radiation treatment can change the outcome of the patients and how it can change the quality of life. For this, we have a patient of lung cancer today who was treated by one of the newest technology of radiation treatment called SPRT. And this will be discussed by Dr. Sai, my colleagues, Dr. Sai, Abhirama, and then it will further discussed by our faculty colleague, Dr. Aman. So I invite Dr. Sai first.
Good afternoon, everyone. I'll be starting the session with a case of a 60-year-old male, farmer by occupation, with no known comorbidities. He has a history of smoking since 30 years, 1 packet per day, presented to us with complaints of chest pain on the left side for 3 months. He also had a history of dry cough for 3 months and history of hoarseness for 1.5 months. He has a history of shortness of breath on exertion and had difficulty while walking just after 10 to 15 steps. There was no history of fever, hemoptysis, weight loss, or decreased appetite. His ECOG performance score was 1, and there was no lymphadenopathy, and rest of the systemic examination was within normal limits. Here is the imaging of the patient. A CCT test was done while evaluating the patient, which showed a well-defined soft tissue mass with spiculated margins measuring 3.8 into 3.3 into 3.3 centimeters in the left upper lobe in anterior segment. There is also a lymph nodal mass in the mediastinum measuring 4.3 into 2.5 into 3.4 centimeters, which was encasing the left pulmonary artery. For further evaluation, a PET CT scan was done, which showed a FDG avid subpleural soft tissue lesion with spiculated margins in left upper lobe with size of 4 into 3.6 centimeters, which was abutting costal and mediastinal pleura. There is also a FDG avid confluent necrotic nodal mass in the prevascular and AP window measuring 4.2 into 3.5 centimeters. There is also a FDG avid 6 millimeters nodular lesion in left cerebellum, which was further evaluated with a CE-MRI brain, which showed well-defined 8 into 7 into 9 mm lesion in the adjacent perilesional edema in left inferior cerebellar hemisphere in subcortical location. As you can see in this image pointed with an arrow, there is a lesion in the left cerebellar hemisphere. A biopsy was done from the left lung mass outside, which was then reviewed in AIIMS, which showed adenocarcinoma. Immunohistochemistry was positive for TTF1, and other predictive markers such as EGFR, ALK, and ROS1 were negative. Patient was diagnosed with carcinoma left non-small cell lung cancer, adenocarcinoma, and a TNM stage of T4N2M1B and a stage group 4. Further details of the management and the challenges that we faced during the management will be discussed by Dr. Abhirama.
Good afternoon, everyone. The patient treatment was discussed in our multidisciplinary team, which includes radiation team, medical oncology, radiology, and a nuclear team. The plan was finalized. There were two options. One, to go with the ablative therapy to the brain lesion, followed by a systemic therapy, which intended with the palliative intent. The next one was the radical total ablative therapy to the gross disease, which include the primary mediastinal mass along with the brain lesion, followed by a systemic chemotherapy. Patient was counseled with both the option, and we decided to proceed with the option 2, which includes the ablative therapy. SBRT. SBRT is a highly conformal form of radiation in which very high dose is given to the target disease and with a steep follow of the dose to the neighboring structure. So we can preserve the neighboring ORs, that is organ at risk, can be preserved. With this procedure, we have prescribed a dose to the lung of around 65 gray in 8 fraction. The dosage in the case of lung CA, it depends upon the location, whether it is in the central or in the periphery. If it is in the peripheral location, we can hypofractionate of 18 gray in a 3 fractions to a 54 gray or a 60 gray in a 3 fraction we can give. But here the disease was around the central mediastinal compartment, so we have to fractionate. So here we are given in a 65 gray in 8 fraction, followed by the mediastinal lymph node of 48 along with the mediastinal lymph node of 48 gray in 8 fraction, which was treated 4 times a week over a period of 2 weeks. The advantage of SBRT is it is treated very high doses and the number of fractions is very less. The treatment time will be less than 1 to 2 weeks. Along with the SRS dose to the brain lesion, which is 30 gray in 3 fraction. Usually brain less than a sub-centimeter lesion can be given in a SRS of single setting, but here the lung and the mediastinal lymph nodes are very big, so we have to fractionate the brain lesion. The challenges in this case are the lung mass was around 4.5 centimeter and the mediastinal lymph node was around 4.5 centimeter, which were very close to each other, which is around totally around 9 centimeter, combining both the together. So this was our there was a challenge during our plan. Conventionally, SBRT is done for a masses around 5 centimeter. So this makes around 9 centimeter for mass to make a SBRT plan. The other one was the mediastinal structure. Here the mediastinal lymph nodal mass were very close to the bronchus. The planning part was very challenging in this case. The workflow, the SBRT workflow in our department. The first step is immobilization. Immobilization is an important step in a radiation planning where the patient is made to lie down in a particular position, which will be subsequently carried throughout the treatment. The position should be easily done and it could be easily reproducible. It should be done throughout the treatment time, the position. Followed by the CT scan will be done, which helps in the planning of the patient, in which we contour, which includes both the target, which includes the gross disease and also the adjacent neighboring structures, which we have to preserve. We have to contour that. Followed by we will prescribe a dose and the planning will be done. SBRT planning will be done. The SBRT planning is also is an inverse optimization. Generally, we will put a plan with a dose prescription. Here we will try to preserve the organ at risk. So it's like an inverse. We have to give a dose like tumor ka itna dena hai and organ ka itna jana hai. Bolke we'll the plan. Then computer will generate the plan for that. We'll give a target. With that, the plan will be generated. Then we will implement the plan in the machine on board. We will deliver the plan with the onboard 3D image or 4D image. During daily treatment, we will take images. So the steps involved in the immobilization. Here the patient can be seen. Patient is lying comfortably in a supine position with the arms above head, and we have given a cushion. It's a cushion. Here it's the colors of backlock, in which the patient is made to lie comfortably. This is made up of polystyrene and inside there will be a styrofoam beads. After once a patient is slide down, we will have there is a vacuum bag is there. We will connect to the vacuum, so the vacuum will be suctioned out of the bag. So it will assign the shape of the patient. So it can be used throughout the treatment. Along with the abdominal compression. The one disadvantage, main thing in the lung primary is both the organ and the tumor moves with the respiration. So when we plan, even a lighter movement with the respiration can miss our target. So to reduce the movement of the organs, we use a procedure called the abdominal compression, which will, with the negative pressure, it will reduce the motion of the diaphragm. So the lung and tumor movement will be reduced. Followed by, we will take a CT scan in which the immobilization is carried out along with the 4D CT. We have taken a 4D CT. 4D CT is a special technique in which along with the normal CT scan, time will be incorporated. With each movements of respiration, CT will be generated. Each phase of respiratory cycle is divided into 10 cycles. So CT will be taken 10 times the normal ones in this. CT will be taken. In this, we can see there is a marker on the surface of the patient. It is called infrared marker, which will assess the motion of the patient chest movement during a respiration, which will be captured by the sensor, which is inbuilt in the room, which we can monitor in the system. Next is the delineation, target delineation. We have to draw, we call it as a contouring. We will draw both the normal structures and also the targets. Here we can see this is the primary disease, the lung primary, which was contoured in the red color. Following by there is a mediastinal lymph nodes, which is also contoured in the yellow color, which will be contoured in each and every slice. In the case of high-end technique like SBRT, the CT will be taken very small slices, 1 to 2 mm will be taken. We have to contour in each and every slices to see the doses. And the neighboring organ at risk is also contoured. Here we have contoured the arch of aorta, descending aorta, and the pulmonary trunk is contoured. This is our target. We have to contour the nearby organs at risk, which are the neighboring structure which is going to receive the dose while treating this primary tumor, which includes the entire lung. In the axis section, you can see the entire lung and the esophagus, the bronchus, the pulmonary trunk, the arch of aorta and the descending aorta. You can see we have contoured lungs also here, and the spinal cord can be seen in the sagittal section. After contouring, once the contouring of both primary mediastinal lymph nodes and the organ at risk was finalized, then we will send the patient to the planning, that is a dose distribution. It is a software based planning in which we will prescribe the target should receive this much dose and the OR should receive this much dose. Then the plan will be made. Uh, this color represents the dose received by the particular structure. We have prescribed a 65 gray to the tumor. This is a 95% of the 65 gray, that is 63, around 63. This is a 63 gray. This green color represents the area received by the 63 gray volume. So we can see this ideally it is covering the entire structure. The main advantage of the SBRT is the rapid dose follow-up, so that the neighboring structures don't receive any structure. Here it is a 50% of the prescribed dose. This is a 32 gray. We can see the falling off is within 1 to 1.5 centimeter. This red color represents the target highest doses, that is around 64 to 70 gray. This blue represents the lower doses volume. This is around 32 gray. So it is like a rapid follow-up. The neighboring structures can be preserved. Here we can see the sparing of a normal organs. Here the mediastinal, the challenging in this case was the mediastinal lymph node was close to the great vessel and was close to the main primary bronchus on the left side. So these are the two critical structure. Over radiating or toxicity of these structures may lead to the stricture, stenosis of the bronchus, or a massive hemoptysis or a bleeding, which may lead to death. So we have to reduce the doses to this structure to keep as low as possible. So the dose to the primary bronchus was reduced. This is a 95% of the 48 gray volume. It is around 46 gray, and there is a rapid dose follow-up in the primary pulmonary bronchus region. Here also we can see both the side bronchus was preserved with receiving the dose to the only the mediastinal lymph node volume. Then treatment. Once the plan has been finalized, then the patient will be implemented on the machine. The patient will be made to lie down on the same comfortable position in a vac lock with the abdominal compression, and on couch images will be taken. The patient, our Linac machine has an inbuilt CT. We can take a CT during every setup, and we will match the CTs on the planning CT, which we have taken to the initial planning CT, and daily CTs will be taken, which will be matched daily to see whether there is any error, and we will try to correct the error. Here there are two CTs. This is the initial planning CT, which we can see the mediastinal lymph node, which lies within the yellow colored structure. This is the on couch where the patient, after the patient has lie down on the machine, the CT was taken, and the target structure was lying within the yellow colored structure. So matching was done. We will try to avoid error as much as possible. We'll keep an error up to 1 to 2 mm will accept, and we will treat daily with the CT. Plan CBCT on which. After the completion of radiation, patient received RT for 3 weeks, followed by 3 weeks of gap. Patient was started on a systemic chemotherapy, and the response assessment PET was done after the 5 months of completion of treatment. Here, this was the initial primary tumor, which showed now there is a regression in the primary, and the mediastinal, initially it was FDG outward, now there is a complete regression in both the structures. There was a partial response, there was a minimal residual disease there. And the present status of the patient was presently 90% pain relief, not taking on any pain medication. Occasionally he takes. There was no cough and hoarseness of us. Initially he had a difficulty in speaking. Now he has improved symptomatically, and there is no complaint, and there was no RT toxicities also. The RT induced toxicity like pneumonitis or esophagitis, there is no toxicity. Patient is doing well. He is on 3 weekly pemetrexed maintenance now. Now, so we'll be speaking on SBRT in the lung patient.
Good afternoon, everyone, and thank you, Dr. Abhirama. So before, I would like to rediscuss what were the challenges that we faced while treating this tumor. So normally SBRT is delivered only in 5 centimeters, and like we had two tumors. This is the first one, the primary tumor, which is close to the major vessels and the mediastinum. Also, the second structure is within the mediastinum. So we have the great vessels, we have the trachea, we have the bronchus, we have the pulmonary tracheobronchial tree, and we have the esophagus. So any dose to these structures, giving a very high dose is very challenging, and in the literature review, this has been associated with not only morbidity but also mortality. There have been reports of death while giving radiation to this area, and there have been fatal hemopsis which cannot be stopped, and immediately it's fatal. Also, there has been formation of tracheoesophageal fistula, and also stricture. So this was a very challenging case, and we went beyond the guidelines because it's normally recommended for 5 centimeters, and here the tumor bulk was roughly 9 to 10 centimeters. So this also posed a further challenge because radiation pneumonitis would also increase because the mass is very high, and luckily the patient did well, and his hoarseness of voice, the recurrent laryngeal nerve palsy, has also improved. His voice was very husky, but now he's very happy, and he can speak a lot. This little bit of residual disease, it's very difficult to say whether this is a residual disease, because when we are giving a very high dose of radiation, there's vascular injury and there's oozing out. So such uptakes can be there. Because the mediastinal node received very less dose of 48 gray, because this is a very critical structure. So this is in complete response. So this could be a radiation change rather than a residual disease. We'll follow it up with the next PET scan, and we will see whether this is a residual disease or it's a radiation change. So now coming on to the data, we all know that oligometastatic disease does exist, and in this heterogeneous group we have prospective randomized data to suggest that SBRT is associated with improvement in overall survival. As you can see, there's an improvement in overall survival from 28 months to 41 months, which is very substantial, and with the hazard ratio of 0.57 when you add stereotactic body radiotherapy, or we are ablating the gross disease, and we can see that as the time passes the curves separate out. So this means that the treatment is very effective. Also, there was a little like 20% 20% more adverse events, but it's grade 2, not grade 3. And also there were a little bit of mortality, 4.5%. So again, this is challenging, especially for when you have an ultracentral location and the tumor is very close to the mediastinum. So we have to be very careful. Again, and these the author Parma et al. Updated their results, and with the median follow-up of 1 month, the 5-year OS was merely 18% when SBRT was not given in stage 4, and it was 42%. So marked improvement when you are adding SBRT or local ablative therapy to the metastatic disease. Also interestingly, what they found is that there was improvement in OS, but the distant metastasis, time to new metastasis was not different. So primarily the effect was because of controlling the primary tumor. And of course, there was no more grade 2 or grade 3 events, and there was no difference in quality of life between the two arms. Now, this was a heterogeneous group of oligometastatic disease, but like colorectal primaries or prostate, they are indolent biologies, and in these subset of patient can have long survival, but you know that lung is very aggressive, and does really a oligometastatic disease exist in this one? So this is the systematic review that tried to answer this question, and this was published by Ashworth et al. In 2013, and it included 49 studies and more than 2,000 patients. Majority of the patients had a controlled primary, and 60% had brain metastasis. So what we see is that overall survival in oligometastatic is very heterogeneous. So 1-year survival can be from 50 to 15% to 100%, and 5-year survival can be 8.3 to 86%. Mind you, this is non-small cell lung cancer, so 5-year survival can be as high as 86%. So you don't get normally in advanced stage 4. So it's very heterogeneous. There will be a subset of patients, if treated aggressively, they may attain a good survival. So but it's also important to note that 50% of the patients would progress within 12 months. So the median time to progression was 12 months and the median OS was 14.9 months, that is 15 months. So because this was a heterogeneous cohort, so the authors tried to find out what were the prognostic factors that could be responsible for like better survival. So they found out that definitive treatment of the primary tumor, the end stage, and the disease-free interval of appearance of metastasis predicted the survival. So the systematic review concluded that survival outcomes are very heterogeneous. Half of the patients would progress within 12 months. However, long-term survival does exist, and definitive treatment to the primary tumor and the low burden thoracic tumors are strongly associated with the improvement in survival. So this is a good evidence to suggest that not only in stage 4 chemotherapy should be added, but also ablative therapies have a major role to play. Again, the authors, because this was a very heterogeneous group, again they tried in 2014 and they tried to see what were the prognostic factors, because having a 1-year survival of 15% and a 5-year survival of more than 80% in a metastatic disease, we need to know which one to target and which one to leave. So on a multivariate analysis, the long-term survival was associated where when the tumor was synchronous, they had a better survival than metachronous had a better survival than synchronous. Interestingly, the intrathoracic nodal status, despite having metastasis, predicted survival. So N status predicted survival in M disease. So if it is N0, then survival is better. If it is N2, then it would be worse. So they stratified these patients into 3 categories. On the low risk group, which had the best survival and comprises of the metachronous metastasis, the 5-year-old survival is 48%. The synchronous metastasis, when there is no lymph node metastasis involvement, the 5-year survival is to the tune of 36%, which is also very good for a lung cancer stage 4 disease. And when the presence of synchronous metastasis and an N1 N2 disease, this is a high risk group and the 5-year-old survival is very less, but this is still encouraging because it's a synchronous disease and it's stage 4 lung. So even if 14% patients survive at 5 years, I think this would be an achievement as well. So now we know that there's a oligometastatic state exists in lung cancer also. But is there a role of local ablative therapies? The answer would be when we see the pattern of failures in metastatic disease. So this was the first study published in Acta Oncologica that tried to address this question. So looking at the pattern of failures, 90% of the tumors would fail at the primary site. 90%, and local failure only would be at 64%, local plus distance would be 27%. So this is very important that when the advanced disease fails, it fails at the local site. And also they found out that of these advanced disease, some patients were eligible to the SBRT. And interestingly, what happens is that those patients who were eligible to SBRT, if not given, then there is a rapid progression, so within 3 months. And if they are not SBRT eligible, then the progression is late. So that's more important a reason to ablate these tumors. Again, this is a randomized phase 2 trial, which again showed that in stage 4 non-small cell lung cancer with 3 or few metastases, who received induction chemotherapy of greater than 4 cycles of platinum doublet or greater than 3 months of EGFR ALK inhibitors, were subjected to either maintenance or maintenance plus SBRT, that is local ablative therapy. So the median progressive, the PFS after local consolidative therapy was 4 times better, mind you, 4 times. 3 times. So it's like 4 months versus 12 months, and a hazard ratio of 0.35. And the 1-year progression free survival is 20% if you add local ablative therapies, but if you don't add, 50% will progress within 1 month. Also interestingly is like the heterogeneous cohort of all oligometastasis in the trial by Palma et al. In non-small cell lung cancers, when you are ablating the local, when you are ablating the gross disease, the time to appearance of new metastasis is doubled when you're adding local therapy. So that means that when you're adding local therapy, it is not only controlling locally, but it's also reducing the tendency to throw distant metastasis, and it is prolonging survival, not and also the appearance of new metastasis. The adverse events were similar in both groups, and there was no grade 4 events or death rates. This is another phase 2 trial which shows the similar it was it's a similar arms, but this was not in ALK mutated or EGFR mutated cohort. And what an encouraging result that the trial was stopped early in a stage 4 disease. There's a massive improvement in progression-free survival when you're adding local ablative therapies, and this trial was stopped because of such a huge difference in benefit, and toxicity was similar in both arms. So all this data was before the immunotherapy, and this is a phase 3 trial because immunotherapy is also effective. So when we add local ablative therapy to immunotherapy, again this is a single arm phase 2 study, and it also shows that the median progression free survival was very encouraging, and it was far better from 19 months to like a dismal or 6.6 months. So even in immunotherapy, when you control the local primary, the results seem to be very encouraging. Also, our patient was in a high risk group. It had a synchronous non-small cell lung cancer. So we need to know how to actually define synchronous oligometastasis, because some group there may be like florid metastasis, and by definition we may treat them aggressively and they may have a dismal outcome. So this is a consensus statement published in Journal of Thoracic Oncology recently in 2019. So maximum of 5 metastases, not more than in 3 organs, are labeled as synchronous oligometastasis, and the mediastinal node is not counted as a metastatic site. So only the distant metastasis will be included, though the mediastinal nodes would account for the prognosis, and presence of N1, N2 disease would be bad. But generally, when you're counting the synchronous oligometastasis, the lymph nodes are not to be included. And the FDG PET and the brain imaging are considered mandatory. And if there is a solitary liver metastasis, dedicated liver magnetic resonance imaging is warranted. Similarly, if there is a solitary pleural metastasis, then thoracoscopic and biopsy is to be done to confirm the metastasis. So all in all, I conclude that all patients with oligometastatic non-small lung cancer should be offered local ablative therapies to the gross disease, because there's marked improvement in survival. Thank you for listening to me, and if there are questions, I'll be happy to take it. If there are no questions, then we can switch over to next presentation.